Yeah, we have only Dr. Syed Bashir with us, sir. Dr. Syed, can you hear me? If you want to introduce yourself, you can, sir. We have still time. I'll just ask Sendil, sir, if he is joining.
Yeah, please. Mm.
It. Yes. You offer it so that they cannot see it.
Yeah. Dr. Mukul, can we start? It's 8:05.
Another 2 more minutes, sir.
Two
Wait
more
for.
minutes? Yeah, yeah,
Yeah, yeah, yeah.
done.
So, I'll just introduce you and then you can start sharing your screen. 2 more minutes. We'll just
Sure,
wait for a
sure,
few more participants to join, sir. That's all.
sure. Done, 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 done.
Okay, it's 8:05, sir. We'll start. Okay. Welcome everyone to today's Ophthall Surgical Video Club. This is the Telegram group. So if anyone wishes to join the Telegram group where we update regarding the club and you can ask the queries, you can join. So this is made possible by our Ophthall imaging system. All the details are available at ophthalmart.com. So myself, I'm Dr. Mukul. I have my own hospital in KGF. I do mainly cataract surgeries. So today our speaker will be Dr. Lalit Kumar sir. So he's the chairman, Department of Ophthalmology and of Amrit Hospital and Amrit LASIK Center in Chennai. So sir is a known famous surgeon. So perform a lot of live surgeries along across all our southern states. So I think he'll be the best person to talk regarding this interesting topic of extreme eyes and also regarding LASIK workup because sir is I think one of the pioneers here in regarding LASIK and refractive surgeries. So it will be very interesting to hear from him. I hope everyone will have a interesting educational session. You can pause in between to ask questions, or you can type in the chat if you want me to ask sir any doubts along the way. So over to you, sir. I'll stop sharing my screen. Yeah, now you can start yours, sir.
Good evening to one and all. In the first place, I'd like to thank Dr. Mukul, Dr. Sendil, and the entire team of Ophthal for giving me this opportunity. Are you able to see my screen by any chance? No.
Sir, we are able to see your screen. The PPT is not yet opened. The
Yeah,
presentation
so
is not
I
yet open.
think just a minute, I'm not able to.
Yeah, now it is.
Now it is.
Now
It's
open.
happening. Yeah. Right. So I just have to play. Dr. Mukul, the only yes. Yeah. It is. It should work now. So my first topic is about phaco in extreme axial lens. See, we come across patients who are high hypermetropes or high myopes. Now, they are always a challenge when we do cataract surgery in these patients. So this is just a video presentation where we encounter two situations, and I'm just showing you some small tips how to handle these situations. So what are the challenges in myopic or large eyes? One is the biometry. The chance of retinal detachments is very high in these patients because they are myopes. And there is increased depth of the anterior chamber. Obviously, the anterior chamber during the surgery deepens whenever we go in with the phaco probe inside because of the flow. And this causes an reverse pupillary block, which also has a fancy name called lens iris diaphragm retropulsion syndrome. So I just don't want to go into fancy terms. It's basically a reverse pupillary block where the iris gets stuck to the anterior capsule. And that causes a lot of pain to the patient because there is a stretch of the ciliary body also. Patients who are high myopes also have a little bit of floppy iris, and the chance of iris prolapse is also high in these patients. And the pupil also constricts during surgery. So once the phaco is over and when you want to do the cortical aspiration, the pupil also constricts. So these are the usual challenges which we face when we deal with myopes. And there is also pain, which I mentioned earlier. Whenever you go in with the phaco probe inside the eye, because of the sudden deepening of the anterior chamber, there is a ciliary body pull, which causes a lot of pain. So you would have noticed that most of the patients, high myopes, say that, sir, whenever you enter, they say, sir, it is paining. So we'll have to, come up with small techniques which will reduce the pain for these patients. Now, the challenges in hypermetropic eyes or small eyes are basically, again, the biometry. They generally have a dense cataract because they get that second sight, which we call, right? Because there is nuclear sclerosis and then the patient is able to see everything well without glasses itself. So they don't bother to come to us. The chambers are shallow, the eye is small, and generally they have a narrow palpebral fissure also in hypermetropic eyes. The corneal endothelial trauma is more because of the smaller anterior chamber depths. There's a lot of positive pressure during the surgery. The pupils might also be small, and there is a high chance of choroidal effusion in hypermetropic eyes, and chance of expulsive hemorrhage is also more if you're going to do something like ECC or sometimes even SICS. But with phaco, the chance of expulsive hemorrhage becomes drastically less. So in patients with large eyes or myopes, we generally have to make sure that we get a right biometry. So we use the right equipment, basically an optical biometer and the formula. Now, universally used formula is the Barrett's Universal 2 formula, which is available with most of the modern day optical biometers. But we can also use the SRK by T for axial lens, which are greater than 22 in size. A good retinal evaluation and treatment if required. If the patient has any holes or lattice, you can barrage the holes, provided you are able to see them. Sometimes if there's a dense cataract, you won't be able to notice them. Then you have to use lower parameters during phaco to reduce the chance of pain and, as I told you, a reverse pupillary block. This is mainly by lowering the bottle height or reducing the intraocular pressure. See, nowadays machines have I use the Centurion and the Unity. You can set the intraocular pressure which you want inside the eye. So the chamber is very well maintained, and the entire atmosphere inside the eye is very well controlled. So the chance of surge, pain, everything comes down. And you can also use phenocane or any other brand to maintain the pupillary dilatation and reduce the iris prolapse and what do you call that? Floppy iris. And you also reduce the number of times you enter the anterior chamber, and also fill with the anterior chamber with viscoelastic before you pull out the phaco probe. So this reduces the surge or the sudden decompression of the eye, which can again lead to some kind of a drag on the retina and cause a retinal detachment or a retinal tear. So these things we have to maintain. So whenever you come out of the eye, try to inject viscoelastic from the side, especially in myopic patients, before you remove the phaco probe from the eye. And measures which we can take in in small eyes are biometry using the right equipment, as I told you. Barrett's Universal 2 is an amazing formula, but you can also use the Hoffer Q if you don't have the Barrett's for axial lens less than 22 millimeter in size. And you can lower the parameters for phaco except for the bottle height. You need a slightly more bottle height because you need more fluid inside the eye to maintain the chamber at depth. We can use chondroitin sulfate to protect the endothelium in these patients. And we should be quick in and quick out of surgery. You should not be spending too much of time. And if you can do the surgery a little faster, you can actually, reduce the endothelial cell loss also in these patients. PI, see, most of these patients might also have a PI. So you can plug this PI with chondroitin sulfate, which reduces the chance of vitreous hydration and aqueous misdirection syndrome. So you can just go to the PI and put a little bit of chondroitin sulfate there so that the fluid doesn't go through that PI and doesn't hydrate the vitreous. Because whenever you do a PI, there'll be a little bit of, zonular loss also there. So the fluid can get into the vitreous in these patients. And one more thing which I generally do in these small eyes is I use hypotensive anesthesia. So if you have an anesthetist, you can ask them to give IV metoprolol, which reduces the chance of choroidal effusion and expulsive hemorrhage in these eyes. This is a small video of a 33-year-old man. You can see the axial length is only 19.74. I'll just reduce the volume. So you see that I enter the eye, the pupil is already small, and there is absolutely no space. The anterior chamber depth is so minimal. Okay, so I try to go in with my Utrata forceps, but there is no space. So what I do in these patients is either you can use a 26 gauge needle on a 1 cc syringe and aspirate the vitreous a little, or even better, if we can learn to put a pars plana port and do a minimal vitrectomy, that itself will increase the chamber depth. As you can see here, now the chamber is nice and deep, and even the pupil is dilated a little. So in this patient, I'm using the Utrata forceps to make my rhexis, and it makes my life easier because I have more space in the anterior chamber now. So this is an amazing technique, and in fact, I use this for my phacomorphic patients also. If a patient comes with a phacomorphic glaucoma, I do a little bit of vitreous tap. Either you can aspirate, or this is the best way, this is more controlled. You can do a vitrectomy through the pars plana and make sure you can just feel it with your other finger, whether the eyes become soft. And once that happens, you can proceed with the surgery, and it makes our surgery very, very easy. This is the routine phaco. Once you get a nice chamber depth, you can just do your routine phaco. This was a very soft cataract, and as you can see, it just comes out with phaco aspiration itself. You don't have to use any phaco energy. So that's the end of this case. So my suggestion is everybody should learn how to put a pars plana port. This is one thing which is going to be very, very helpful in a lot of situations. Even in aqueous misdirection, sometimes the chamber becomes very shallow, and if you put a port like this, and you just let one drop of vitreous out, that itself is enough. That will give you a lot of space inside the anterior chamber. This is one more video showing a high myope. Okay, now as usual, the surgery is routine. I'm just doing my rexis. I always prefer to do the rexis through the side port because that makes sure that you don't have to inject visco again and again. You can get your rexis in one shot. And the usual hydro dissection, as you can see here, and a little bit of hydro delineation also, which I generally do for most of my patients. Once that is done, I use a viscoelastic inside the chamber. And you can see that once I enter the chamber, you can see that the chamber deepens a lot. So I use my second instrument just to release that pupillary block, reverse pupillary block, and that itself reduces the pain for the patient. That is one amazing thing. At the same time, it reduces the anterior chamber depth also. So here again, during the cortical aspiration, I just went inside the eye, and you can see here that the chamber deepens a lot. So you can use your second instrument, just lift the iris. This is one amazing tip, which, if you use this every time, the pain for the patient also reduces, and the sudden deepening of the chamber, the chamber is too deep. It becomes very difficult for you to access the cataract and the cortex. So that also becomes a little easier. So that is the end of the surgery. These are the two tips which I wanted to give you in these extreme, either high hypermetropes or high myopic patients. Thank you. That brings me to the end of my first presentation.
Sure, sir. If you don't mind, can you go back to the hypermetropic video and myopic video? We'll just have a discussion regarding that, sir.
Definitely. So this is the first video. I'll just play it again. I'll reduce the volume. I'll just switch off the volume.
Yes. Thank
you.
If
Anybody has any questions on this, you are free to ask me, and then we'll go to the next presentation.
Yes, sir. My question would be regarding the ELP, sir. In this hypermetropic eyes, what would be your target IOL power, sir? Suppose in your biometry you are getting whether it will be the
in hypermetropic eye, see whether it is hypermetropia or myopia. I generally are you able to hear me?
Sorry, you're audible.
Okay. I generally tend to aim for emetropia only. Okay. Only if it is a multifocal. If it's a multifocal patient, I go for the nearest plus. So say plus 0.12 or plus 0.25. Because I've seen that hypermetrop, if you keep them myopic, right, they are not very happy with their vision. If you leave them a little hypermetropic, they are very, very happy. Otherwise, I generally aim for emetropia in most of my patients.
Thank you, sir. Because hypermetropes are the most difficult patients to satisfy. No, hypermetrop patients are the most difficult people to satisfy regarding the post-cataract surgery. So, what's the percentage of multifocals would you advise to these such of patients, sir?
If it is an extreme hypermetropia, anything above 6, I generally don't go for a multifocal lens because they would have some kind of amblyopia which is already existing and they won't be very happy. So I think the most happy patients are till that 5 plus 5 diopters of hypermetropia. Those are the really happy patients, more than myopes. So these patients are very happy. But extreme hypermetropia, anything above 6, I tell them that you are a good candidate for multifocal, but don't expect amazing outcomes and all, because they will have around 6/9, 6/12 vision, and that's not going to improve. And even the near vision will be N8, so they're not going to be very, very happy. Myopes also, to some extent, I tell them that you will get back good vision, but they again always insist, sir, I was able to read at this distance, now I have to push a little away. So it is just that you have to keep talking to them and educate them on what are the changes, or at least teach them after the surgery also where to keep the near vision chart and where to sit, how far you should sit from the computer. All that, if you explain in detail, I think they'll understand.
And the next question would be regarding the IOL sizing, sir. Since these are small eyes, right? So the capsular bag won't be large enough many times to fit your this thing IOL, and it gets crumpled up or something. So PI, when would you do in all cases, or is there any recommended cases where you do PI and then leave it, sir?
I think if the AC depth is less than 2, I think you can see, but I don't think there is any role for a PI, because once you place the lens inside the bag, right, that itself will give a lot of space for the iris to fall back. Okay, so I don't think a PI is mandatory. See, unless it is a narrow angle or something like that, that requires a PI. But there have been extreme cases. I think 1 or 2 patients I've seen who required an IOL power of 40, 42 and all. So in these patients, you have to be extremely careful. I think it's better to have a retina colleague along with you just to make a small scleral um, window for you, because sometimes these choroidal effusions can all happen. So these are extreme eyes, extremely rare, which you will come across some kind of nano-ophthalmic or micro-ophthalmic eye. So these patients, you have to be a little careful. I wouldn't advise any newcomer to take these cases up, or at least an experienced retinal surgeon along with you in these cases. So if you have a choroidal effusion, he can drain that effusion for you.
Thank you, sir. I see that from the audience, we are not having any questions.
So may I ask the question,
Yeah,
sir?
please go
Dr.
ahead, madam.
Saranya, please.
Sir, what is your endpoint for vitrectomy when you do in a phacomorphic glaucoma? See, you don't have a view at all.
Exactly.
See, these lenses are little bulkier, though they are more than 4 mm in lens thickness.
Exactly.
So how exactly you know that you are in the vitreous cavity one, and it's a blind vitrectomy, and what is your endpoint for vitrectomy? How much you do?
Okay. As you said, it is definitely a blind vitrectomy. There is no way we can, so the only thing is, instead of just going towards the lens, I think it's better to go towards the optic nerve, like you're going to give your intravitreal injection. Keep
Right.
slightly away from the lens. Maybe tilt your hand a little towards the optic nerve. That's first thing. Second thing is, you can use your a bud or maybe your finger also, since it's gloved anyways, to feel on the cornea whether the eyes become a little soft or not. That's the easiest way. You should not make it too soft also. But then what will happen is, there is again, it will behave like a myopic patient. The chamber will be very, very deep. So once you start seeing a little bit of folds, I think this video was very clear. I started seeing a little bit of folds here, and I realized that is the amount of vitrectomy I should do, not more than that. You can see here. I'll just play it again for 1 minute. So I was not able to get in. I put this port. You can just do a little bit of vitrectomy. You can start seeing a little bit of folds in the cornea. If you can slowly notice it, you can use your finger also. Can you see those mild folds? So I think that is the end point. I don't think you should do more than that, because if you do more than that, then the chamber is going to be too deep. You'll have to lift your hand to access the cataract. So it's a very subtle thing. So it's very subjective. There is no end point, or you cannot measure how much of vitreous you're going to remove. It is just a clinical judgment.
There was one drop vitrectomy, they tell, What is that? One drop vitrectomy.
See, one drop vitrectomy is once you put the port in, right? One drop of vitreous will come out. If that is enough, if you can see in very extreme patients like this, that will work well in aqueous misdirections. Okay. But not in these patients. Here, you will have to remove a little bit of vitreous. And you can feel it with your other finger. If it's a little soft, just come out. That's it. That should be enough. And leave the port there. Leave the port there. Just in case you want to do it for the second time, you can still go ahead through that port and do it.
And this is a very basic question. Like, we have our anterior vitrectomy with the Centurion machine. The same cutter goes in through this?
It goes through this because it's a 23 gauge cutter. See, most of these modern machines come with a 23 gauge cutter. So you can use the same cutter go through this.
Fine, sir. Sorry for the very basic question.
No, there's no basic. Any doubts can be cleared here, please.
I have not come across such very smaller eyes, but I have done a lot of phacomorphics here in my hospital. But I used to give IV mannitol. That works pretty much maximum of number of times.
Do you do SICS or phaco for these
phaco
patients?
Phaco only, sir.
No, it works. I'm not saying no, but you try this for your next patient.
I have not tried in a mature cataract this port vitrectomy, to be frank. So maybe I'll try and see, sir.
Definitely, you should try. Definitely,
so in all your phacomorphics, you do this?
No. Not in all my phacomorphics. Sometimes the chamber is too shallow, right? Where I'm not able to get inside at all. In those patients, it's not mandatory that you have to do it for everybody. So sometimes, like this patient, I went inside the eye. I'm not able to, enter itself. In such situation, definitely yes. See, sometimes the phacomorphic may be associated with a little bit of zonio dialysis also. So that itself pushes the lens forward, right? So in such situations, there's no other option.
Sir, one more doubt. The scleral window which you told, no? Can you just elaborate a small thing of how actually you do? I have not seen a surgeon doing that.
I have seen one patient in my entire 21, because see, these patients generally, better to be handled in an institute. Okay.
Fine.
Like yours is an institute, I know, obviously you work at Shankara. So I think they go around 4 to 5 millimeters behind
So
the
you
limbus.
pre-place the
Yes, it
scleral
is done
window.
before the surgery.
Ah,
It is done before you start the surgery. You make an opening, you like a trabeculectomy flap. You make a flap and you make an opening inside, so you're able to see the choroid there.
fine.
Okay, you're able to see a little bit of choroid, and then if just in case you have a choroidal effusion or something, you have to open up that area so that whatever fluid is there oozes out. It's a very risky procedure. I'm not saying it has to be done, but I've seen anterior segment surgeons also doing it. But I would recommend, better to have a VR surgeon along with you who has some experience in this to deal with these kind of cases.
Okay, fine, sir.
This was not that extreme. This was just a shallow anterior chamber. That's all. Very very shallow anterior chamber.
So what is the axial length you expect in uveal effusion? I thought it's less than 20, So that is why I asked.
Yeah.
In a
So I think
navnotomic.
I think 17,
Okay, sir.
16. Those patients definitely you have to be very very careful. Very very careful. This was not a this is a 19 is okay. It's not that bad.
And many a times we see a small corneal diameter where all other parameters are normal. Physically, when you see the eye small corneal horizontal diameter is smaller. It is like 10 mm, like that, less than 10 mm. So does that actually influence your biometry?
I don't think so. No, because biometry is totally based on the keratometry, the anterior chamber depth, and the axial length, right? So I don't think that is going to be make. See, but actually, if it is going to be a small diameter, the white to white is less. Maybe the patient might have a shallow anterior chamber. That's something which you can always read on the biometry, right? But not
Fine.
all small white to whites will have a. Because I've seen so many myopes not fit for ICLs. They'll have a
Okay,
nice anterior chamber depth, but their white to whites will be very small. So
fine.
it's not mandatory that they will have a very shallow. If it's a shallow anterior chamber, then you have to take all these precautions.
So in these, the lens size is always the same. It is the same normal lens which we do, or
We don't know.
you would say
how
changing the sizing of the lens or something. You
there are
pre-order, no?
no,
For
we pre-order,
42
but
diopters, you will pre-order, no?
I think the lens diameter is the same. I don't think they
12.5
can reduce.
only.
Yeah, same 12.5, 13 is what is available with the foldable lenses.
Fine,
I
fine.
don't think you can alter that.
Because I have not ordered such weird
No, I
lenses
don't
all.
think. No, I don't
So
think
just
anybody
want to
makes a
know.
smaller smaller diameter lenses. I don't think anybody makes,
Fine, fine.
because this lens will go in anyway. The haptics will fold itself, right? So I don't think that should be a big concern.
Okay.
Actually, there was a study done, sir. They compared the sizes of the 12.5, 13 and all. I'm not sure of the study. They showed it's the same result, actually. It's all
So I
the
don't think it
main
makes a big
part.
difference.
Yes. So, any other queries from our participants? We'll move on to your myopic video, sir. Just a discussion on your myopia next.
Yeah, sure. I'll do that. I'll just show that video. 1 minute, huh? I'll just forward the video so that we don't waste time.
And same question here also, sir. Your ELP for myopes. What would you take for the
Sorry,
IOL
I
power?
didn't get you. Sorry.
Sir, the refractive part, biometry part, what would be the IOL power you would select for a high myope?
Generally, I aim for emetropia. Okay.
Even in
unless
myopes,
you want to give a micro monovision.
Okay.
Then maybe a 0.75 to 1 diopter of myopia in the non-dominant eye.
And up to what range would you advise multifocals in myopes, sir?
I have multifocals. I think are now starting from 5 diopters itself, from 6 diopters itself. So I advise a multifocal for almost a very high myope also. So starting from 6 diopters, whatever is available, I implant that multifocal.
Does the macular health play a factor, sir? Like you do a pre-op
I'm not.
OCT?
Just a minute. I think the volume of this. I think I'll just stop this. Yeah. Sorry.
Sir, am I audible? Can you hear me?
Yeah. Very clear. Very clear.
Okay, sir. No, the patient's macula, sir. When you make a decision about multifocal, right? What are the parameters which you look for? The patient has a pathological myopia sort of retina. Then will you still go ahead with the multifocal for that case?
No, definitely not. If the retina is healthy, if the vision is at least 6/9, If it improves to 6, 9, I think multifocal is a good choice. But if you are doubtful about posterior staphylomas or some kind of a macular degeneration or anything, I don't think multifocal is a good choice. You can go for an EDOF lens in such situations because that's as good as a monofocal.
And one more thing, since you're a refractive surgeon also, sir, any role of your femto in such extreme eyes, do you think they are helpful, or I think the regular thing will be better in such cases?
See, I think first thing for a femtocataract is a good dilatation. So the first case which I showed you is not an ideal patient for a femtocataract. But yes, I wouldn't recommend in very high hypermetropes. The reason I'll tell you is once you do the femto part, right, the femto laser part of for the cataract, there's a lot of air bubbles which are trapped inside. So I had one situation, one high hypermetrop, and I did a femtocataract for him and his wife. His wife's surgery went on very well. But husband's surgery, I had a kind of, I don't know whether it's a blowout or whatever it is. So already there's air bubbles trapped inside, and the lens was also quite bulky. He was a high hypermetrop with a grade 3 to 4 lens. So if we don't do a gentle hydrodissection, you can have a blowout very rarely. And I had a Renton table, but luckily I was able to manage and put instead of that was also supposed to put a multifocal, but I put a monofocal for that patient. Okay. So in high hypermetropes, I wouldn't recommend, but myopes, yes, you can, because it's a very controlled way of doing surgery.
And your use of CTR in high myopes, sir, all patients, would you go ahead, or only
No, but
toric or something?
there are doctors who put CTRs routinely in these patients to reduce that. What happens is the space between the lens, the bag is sometimes might be so big that you might be seeing a little bit of folds on the posterior capsule. That affects the quality of vision. So if you put a CTR, I think the bag is nice and stretched. You don't have these folds. But I don't use it routinely. I don't use it. So if it is a large white to white where the bag is going to be again a big bag, I think you can put a 13 mm CTR or 13.5 mm CTR into the bag and have a good outcome. But not routinely. I don't use it routinely.
Sir, and post LASIK high myope patients. There was
Mm-hmm.
one patient who has undergone like 20 years prior, I believe. In the first era of LASIK, he has done some 10 diopters in one eye and 8 diopters in one eye. Like that, they have done LASIK for him. And he had a reasonably good vision. He developed cataract. Now, in this patient, he has a toricity also. I placed a monofocal toric lens only. I didn't go for a multifocal IOL. Is it wise to keep a multifocal IOL in these patients?
No. Generally in post-refractive surgery patients, I prefer to put an EDOF lens nowadays.
Okay.
That is my
EDOF
first
toric.
choice. EDOF toric, yes, why not? An EDOF toric can be implanted because those are very forgiving lenses. Multifocal, multifocal per se is a very complicated lens. First is, it splits the light and it has these rings and everything. And already patients, we don't know whether our IOL calculation is going to be on target. See, I'm not saying I don't do it at all. But if I take 1 or 2 readings with 2 different biometers, if it matches, then I go for a multifocal, telling the patient that still you might have some surprises. But if it's not matching, and especially if it has some kind of astigmatism and all, it's better to go for either a monofocal toric or a readoff toric. Those are forgiving lenses.
So in these patients, what is your calculation like? You will be doing in Barrett online toric post LASIK platform or?
No, I see most of the formulas nowadays are available with our biometer itself. So Barrett's TrueK, post LASIK TrueK is available. Then there is a Haigis L also is a wonderful formula. And those were available with the older generations of optical biometers. Like I had the ILMaster 500. Those are also very, very accurate. So 2 formulas are, if you have access to the Barrett's TrueK, that's the best thing. And or else you can use the Haigis also or L also.
Actually, we don't have that. So I did an online platform, Barrett's 2K only I went on, and it gave a good result actually. It had a comparison of all the formulas, shamas, everything, and then gave a reasonably good output.
Definitely. So you can do that also, but since I have access, I don't.
Fine.
I'm not doing it now anymore.
Fine.
In my olden days, you know what I used to do when I started my practice, and when I didn't have an optical biometer also. So we used to do cataract removal on first day, keep the patient FA kick, bring him to the OP the next day, take an auto ref reading, multiply it with 1 point. So if the AR shows 10 diopters, right, plus 10, we used to multiply it with 1.75. So that used to give 17.5
Oh, fine.
diopters, and that used to be so
So the
accurate.
next day you will put the lens. Huh?
No, the next day. The first day I operate, second day I call the patient to the OP, take an AR and multiply it by 1.7 or 1.8, 1.75 or 1.8 and place that lens. That was very, very accurate.
This was how many years back, sir?
Maybe 15, 20 years back. I didn't have an optical biometer at that time.
Oh, very nice to hear. Interesting.
This method is still accurate, sir, for intumescent cataracts especially. The patient is very demanding. I think this is the best method to do. Leave them phakic and then implant the proper IOL. And
Definitely.
I've heard of another surgeon implanting a basic hydrophilic lens temporarily and do a IOL exchange after 1 week with the proper multifocal toric IOL so that the patient ends up with a proper refraction.
More of inflammation. I wouldn't like to do that. I think it's better to leave them a phakic and put a lens the next day.
Yes.
Let us keep it simple that way.
Thank you. Saranya madam, any more questions? Or we'll move on to our next topic?
We'll move on to the next talk, sir.
Actually,
Okay,
my
I'm
next
not
talk is
seeing
a
any
slightly.
questions from the chat. Yeah, please go ahead, sir. LASIK workup.
1 minute. I'll just. So this is going to be a slightly bigger talk. So let's see if you want to cut it in between, we can actually do that.
Sir, we have time, sir. Please go ahead.
Okay. Are you able to see my screen?
Yes, sir. Yes, sir.
Okay. So this is a basic topic. I think this is very basic for Dr. Saranya because she's a corneal surgeon. This is mostly for general ophthalmologists who want to know how to work up a LASIK patient. So by definition, refractive surgery is an optional procedure done to change the refractive status of the patient to reduce or remove the dependence on glasses or contact lenses. But I have one more beautiful definition, which is just called happiness, because the amount of happiness which I see on a patient who has undergone refractive surgery is phenomenal. Just imagine a patient who has 7, 8, 9 diopters of whatever refractive error. The next day he's able to see 6.6 or 6.6 partial. The amount of happiness I've seen in these patients is unbelievable. So that is why I call this a magic surgery. Okay, so in one day it changes the entire patient's life. To be very, very honest with you guys. So to begin with, refractive surgery started with incisions like radial keratotomy, which is not done anymore. And then there came ablative surgery, which was surface ablations, which, as Dr. Sarania said, initially there was no topography or anything. Anybody who wanted refractive surgery, even 20 diopters, they used to just knock it off by doing PRK or surface ablation. Then came lamellar procedures such as LASIK, either using the microkeratome or the femtosecond laser. And later it was upgraded to the lenticular extraction, or as we know as SMILE, clear. There are multiple procedures which basically means lenticular extraction. It is already 8:37, so we'll try to make this talk as fast as possible. Then there are, apart from that, the corneal rings were used basically intact, but they are out of this thing now. And patients who are not fit for LASIK undergo phakic IOLs or ICLs as we call them. I'm not going to go through the physics or this thing. So now, who can LASIK? Who can't have LASIK? Patients who have autoimmune disorders, patients with basement membrane dystrophies, corneal dystrophies, any corneal pathology such as herpes simplex virus induced corneal scars, or a corneal warpage due to extended or long use of contact lenses for a very long time, patients who have severe dry eyes. So this is also very, very important because I have burnt my fingers. The patients who have dry eyes, we have to take them very, very seriously, and they are the right candidates for ICL. Okay, so don't do LASIK in these patients with severe dry eyes, or at least treat the dry eye first and then do the corneal-based refractive surgery. And any family history of ectasia, or patients who have formed full-stage keratoconus. See, sometimes we are so tempted to do refractive surgery for patients, but we have to choose the right patient because we don't want to induce any pathology in these patients for the future. So there are a few golden rules. So for every diopter of myopia, we ablate around 13 to 14 microns of corneal tissue. We remove 13 to 14 microns of corneal tissue. Cylinder also you can consider as one diopter. With microkeratome, we can make a flap of around 130 microns. There are a few microkeratomes which make around 110 micron flap also, but use of microkeratome, at least in the tier 1 cities, have drastically come down. We don't use microkeratomes anymore. We either do surface ablations or we use the femto or SMILE procedures for these patients. Femto flaps range between 100 to 110 microns. So you can make thinner flaps with the femtosecond laser. In PRK, the epithelial thickness is 50 microns. We have to remember that in surface ablations, which we also call it as PRK or epiLASIK, LASIK, or there are multiple names for the same thing. Basically, here we remove the epithelium and ablate on the Bowmans. So that is why the recovery is a little slow in surface ablative procedures. And a residual stroma of 300 microns for flap-based procedures, either whether you're going to do a femto-LASIK or you're going to do a microkeratome LASIK, the residual stromal bed after ablation and after the flap should be 300 microns. That is very, very important to prevent ectasia for these patients. And 350 microns for patients who are undergoing surface ablation, like PRK. We can correct up to minus 14 diopters of myopia, plus 6 diopters of hypermetropia, and plus or minus 6 diopters of cylinder with the excimer laser, provided the patient has adequate corneal thickness. Okay. And a good retinal examination, stable refraction. The age of the patient should be more than 21, because generally after the age of 21, the refraction becomes stable for most of our patients. And a tear film breakup time of more than 10 seconds is very, very important. I don't do Shermer's a lot. I do more of tear film breakup time, because that gives us the quality of tears also can be assessed with the when you use the fluorescein to stain the cornea and check for the dryness. That is very, very important. And there are a few parameters which we have to follow. A keratometry of ideally between 38 to 48 diopters is very, very important. Anything below 38 or anything above 48 should be a little suspicious. So if we operate on a patient who has a keratometry of less than 38, we are going to make the cornea very flat. And anything below 35, see, for each diopter, we flatten the cornea by 0.75. That is something which we have to remember. Okay, 0.75 diopters. So for say if we correct -1, we are going to flatten the cornea by plus 0.75. So if it is 48, we are going to make it 47.25. So that is, we have something which you have to remember. And we should not go below 35 diopters. If we flatten the cornea less than 35, then the quality of vision is not going to be great. Thickness minimum has to be 480 to 500 microns. Anything below that, I don't think cornea-based refractive surgery should be done for these patients. The anterior elevation within I'll be showing you a few examples of this. So we have to read a pentacam. So very, very important to remember that anterior elevation within the central 5 millimeter zone should be less than 20 microns. That is very, very important. And posterior elevation in the central 5 millimeter zone should be less than 20 microns also. So it's easy to remember. There are few books which will tell you 15 or 20, but this is easy way to remember. So remember, elevation points on the pentacam within the 5 millimeter zone should be less than plus 20 microns. Not minus has no significance. It should be less than plus 20. And the difference of keratometry between the superior and inferior should be less than 1.5 to 2 diopters. If it is more than, so say the superior keratometry is 44 and the inferior keratometry is 47, that means we have to suspect keratoconus in these patients. And the best thing and the most important thing is all these suspicious points which I'm talking about, right, should be corresponding on the pentacam. You cannot have superior steepening and inferior thinning. That is not keratoconus. That is just maybe irregular cornea because of some kind of corneal ulcer or some kind of trauma which has left a scar on the cornea. All right. So these are the things which we always have to remember. So now I'm just going to show you a few pentacam pictures. I don't know whether I'm going to, this thing is not going to work. Cursor is not going to work. So this is a typical pentacam of a patient, which is a 4 map. So you can see that the 4 maps has, one is the keratometry map. The other thing is called the front elevation. The one on the below that is the back elevation and the thickness map. So if you actually see a pentacam report, these are the 4 reports, which 4 maps you're going to get with that. So first thing is the keratometry. So as I told you, anything above 48, we have to be suspicious. But in this pentacam, you can see that all the points are within 42, 43. So this is a very normal pentacam. So now you can see that there are rings on the pentacam, right? So the first ring is the 3 millimeter zone. Second is the 5 millimeter zone. Are you able to see that, Mukul? You're able to follow that?
Yes, sir. Yes, sir.
So any point, now coming to the front elevation, within the 5 millimeter zone, if it is more than plus 20, that means that point is suspicious. Similarly, the back elevation also within the 5 millimeter should be less than plus 20. Okay. So keratoconus generally starts from the posterior surface. That is something which we have to remember. That's why we call it form fruste keratoconus, basically starting from the posterior surface. So the bulge will actually happen on the posterior, from the endothelial side, and then only it will come to the epithelial side. All right. So early keratoconus always can be detected on the posterior elevation map only. So any point which is more than plus 20 within the second ring, that is the 5 millimeter zone, is suspicious. Similarly, there will be associated thinning. See, here, there is no thinning. There is uniform thickness all around in the pentacam. Can you see that? So this patient is a normal patient, a normal pentacam. This is the other eye of the patient, which is very, very similar. The keratometry, no point is above. The Kmax, if we call it on the pentacam. If you read the pentacam, I'm not able to show on the cursor. That's the only issue. But to be very, very simple, anything above 48, we have to be suspicious. And similarly, within the 5 millimeter zone, anything more than plus 20 is suspicious on the anterior as well as the posterior surface. Similarly, there will be corresponding thinning of the cornea at that particular corresponding point. So now this is one more patient. You can see that this is the typical with the rule astigmatism with a regular bow tie pattern. So this is a patient with high astigmatism, because you see that there is no point which is above 48. The keratometry is within normal limits. Similarly, on the front elevation map, also you can see that there is no point which is more than plus 20. Okay. Similarly, on the posterior elevation also, you can see something like 16, but that is again at the rim of the 5 millimeter zone. So that is also fine. And there is no corresponding thinning. Okay. So this is also a normal pentacam. You don't have to worry. It's just that the patient has a high astigmatism. Now, this is the other eye of the same patient. Now, this is a very interesting map. You can see that the keratometry looks very, very normal. There is absolutely no skewing or any irregular pattern or irregular bow tie pattern. It is a regular, regular bow tie pattern. Similarly, the front elevation within the 5 millimeter zone, the maximum point which is seen is plus 10, which is fine. But if you see the posterior elevation, you can see this tongue-shaped, elevation here, or tongue-shaped picture, the red area, and you have a point which is plus 24. Can you see that, Dr. Mukul? Can everybody appreciate that? So
Yes,
that point is a little suspicious. Okay. So this patient, I would not post him for refractive surgery immediately, because it is slightly suspicious. But there is no corresponding thinning. If you see the thickness map, there is no corresponding thinning. So we would still say that this is, a patient who is a keratoconus suspect. We are not going to do refractive surgery on this patient immediately. Maybe we can repeat the scan after 6 months. And after that, we can take a call whether to do refractive surgery or not on this patient. Now, this is a typical keratoconus patient. You can see that it hits you on your face. So the keratometry here is already 57. Okay. Similarly, the anterior elevation is 36. The posterior elevation is already gone to 83 or something. And there is severe corneal thinning in the center. Okay. So now this patient has to be treated as a keratoconus patient, and absolute no refractive surgery, at least for the time being. Once we treat the keratoconus, then there are multiple options. Okay. So treating keratoconus is altogether a different topic. There are multiple ways of treating the same disease. I'm not going to get into that. I'm just going to tell you that this is a patient of keratoconus, and this is absolutely no for refractive surgery. This is the other eye of the same patient. The corneal, you can see that the keratometry is already hit 60.3, and the anterior elevation is showing plus 47. The posterior elevation is showing plus 113, and there is severe corneal thinning. The cornea is only 3, the thickness is only 307 in the central cornea. So this patient definitely requires treatment for its keratoconus. So now this is a small way of I'm telling you how to calculate. So if you see a pentacam, right? LASIK, as I told you, for LASIK or any flap-based procedures, the stromal thickness, residual stromal thickness has to be minimum of 300. And for PRK or surface ablation, it has to be minimum of 350. So I'm giving you one example of a patient with a PACI of 550 microns, and the patient has a refractive error of -5 with -1 cylinder. So I'm just going to open my calculator here, provided the pentacam is normal. So first thing is we have to rule out that the pentacam is normal and there is no keratoconus. Okay. And so this patient has, say, 6 diopters. So 6 into 13 is going to be 78 microns. So if you're going to make a flap of around 130 microns also, okay, so 550 minus 130. 550 minus 130 is going to be 420. And in 420, if you're going to ablate around 80, we still have a corneal thickness of 330, which is a safe zone. So in this patient, we can go ahead with either a microkeratome LASIK or a femto LASIK or even SMILE for this patient. Just in case the same patient has a corneal thickness of 490, then what happens is then we are going to 490. If you're going in this patient, we'll be able to do only a PRK, or because if for we are going to the epithelial thickness is going to be 50 microns, so the patient is going to be left with 440. And in 440, if you're going to ablate 80 microns, then the residual stromal thickness for LASIK won't be enough. It will be around 280. So this patient is not an ideal patient for femto LASIK. Either we can do an ICL or a PRK at the max. I would suggest an ICL would be a better option because it's too thin of a cornea and better to avoid these patients for refractive surgery. And similarly, if the PACI is 550 and the patient has a higher diopter, like -9 with -1.5 cylinder, then this patient is ideal for a femto LASIK because a femto LASIK gives you a margin of going up to 100 micron flap. Okay, so you get 30 microns more. So my point which I'm trying to drive is we have to actually mathematically calculate. So as I told you in my initial slides, for each diopter of myopia, we ablate 13 microns. So that's something which we have to remember for our calculation. All right. And the residual stromal bed should be 300 and for LASIK and 350 for PRK. So based on that, we can do a mathematical calculation and come to a conclusion. And similarly, I told you for one diopter of myopia, we are flattening the cornea by around 0.8 or 0.75. And one diopter of hypermetropia correction, we are going to steepen. See, in LASIK, it is very, very simple. Okay. What do? We basically remove corneal tissue in myopia to make the cornea thinner and flatter. And in hypermetropia, it's the reverse. We cannot, steepen the cornea. Okay. So in myopia, what we consider is the cornea is like a hill. We ablate the center part of the cornea and make it flat. Okay. And that removes changes the curvature, corneal curvature, and removes the power. Similarly, in hypermetropia, we consider the cornea as flat. Now, you cannot steepen the cornea, right? You can actually flatten by using ablation. But how do you steep? So what we do in hypermetropia, we fire the laser in the periphery, okay, like a ring. And when the periphery becomes flatter, the center becomes relatively steeper, okay? But in real life, hypermetropic patients coming to you for LASIK will be very, very minimal. You will be mostly dealing with myopic patients. And in hypermetropia, the regression is also very high. Okay, so in hypermetropic patients, you always have to tell them that 90% of the times it will be fine, but 10% of the times you might get back some power. But in myopes, the results are amazing because most of the times 95 to 97% of the patients are very, very happy with the results and they don't have any regression after some time also. So these are some videos I'm just showing you. This is about the microkeratome, which I use at my place. This is a pendular microkeratome. This is the first video is about the assembling and the second video is on the making of the flap. As you can see here, the blade is loaded in that and the motor rotates and makes this flap for you. I rarely use this anymore, but this is how a microkeratome actually looks like, and we can make the flap with this. Usually the flap has a nasal hinge, or you can have a superior hinge in these patients. But with a femto laser, you can have a hinge wherever you want. 360 degrees, wherever you want, you can have a hinge, wherever you're comfortable with. So this is a video of LASIK. So first thing is we make these corneal marks for most of my LASIK or femto patients, because after you make the flap, just in case if you have a complication, if you have a free flap or something, it is easy to align at the end of the procedure. Like, you have a free flap, the flap is in your hand. Then you can always align it, and free flaps can happen with the microkeratome LASIK. It is impossible with a femtosecond laser or the advanced procedures like SMILE. You won't have these complications. So this is the typical pendular microkeratome making the flap for us. It takes only a few seconds. This is a wonderful technology. I'm not saying we should give it up, but definitely when in the era of femtosecond, which has made making flaps so predictable, so safe, I don't think it is fair for us to use this technology anymore. And most of the companies don't make microcretomes anymore. They've all stopped. Okay. So this is how the flap is made. And then I'm just going to lift the flap as I'm going to show you here. This is a superior hinge. Yes, this is a superior hinge. Once we focus the laser and then we fire the laser on the cornea. Most of these lasers have an amazing eye tracker. So even if the patient moves a little, the laser firing realigns and fires on the cornea. So we don't have to worry. And if there is gross movement, the laser will stop on its own. Okay, so these eye trackers are really, really good with these new machines. That's it. Once the ablation is over, you just, hydrate the cornea, put the flap back and nicely stretch it. So this is how I, put the flap back. You can again wash under under the surface of the cornea to make sure there are no debris or no foreign bodies or no filaments inside, because few centers use lint. So sometimes this lint again goes and gets below the flap. So that has to be made sure that we wash it off and nicely stretch the flap. That is the end of the procedure. So talking about the femtosecond laser, you can see that it has a suction ring, as you can see here, which is placed on the cornea. And then it has a docking device also, which goes and sits on the cornea. I'll just show you a video on that rather than showing you. So this is how we dock with the femtosecond laser. You just place it on the cornea. And once the dock happens, see, basically the femtosecond laser works like our Nd:YAG laser. It's a plasma laser and it cuts the tissue. It's a photo-disruptive laser. So it cuts the tissue. It basically splits the tissue. And similarly, once the flap is made, it is very, very predictable. You will never get a free flap or anything. So it makes the surgery very, very safe. Similarly, just like you have to lift the flap, fire the laser and put the flap back, as you can see with this in this video. And the flap is nicely stretched. PRK is a very, very simple procedure. There's no, you don't require fancy gadgets. You just have to, use, you can use a trans PRK also, because now the excimer laser itself is used to remove the epithelium, put the speculum. I use absolute alcohol for removal, easy removal of the epithelium, but there are various ways. You can use absolute alcohol, or you can use this is the alcohol well, as you can see here. We keep the alcohol well and we use 20% alcohol. So we dilute absolute alcohol and use 20% of the alcohol. We keep it for 30 seconds. And once that is done, we keep the alcohol well to make sure that the alcohol doesn't spill on the conjunctiva, because that causes a lot of inflammation and burning sensation for the patient. Once that is done, we can just remove the epithelium and fire on this is the epithelial hole. You can just remove you can see how nicely it comes off, because because of the use of absolute alcohol, the epithelium gets degenerated and it just comes off very nicely. The only thing is the recovery is a little slower with the PRK because there's no epithelium. Plus, there's a lot of haze. To reduce the haze, we use mitomycin C on the cornea. So after the ablation is done, after the laser is applied, we use mitomycin 0.02% on the cornea. And I keep it like per diopter, I keep it for 10 seconds. That is my usual timing, which I keep it for. And this reduces the haze as well as pain post-surgery. A small video on smile. See, how does smile work? A lot of patients, a lot of doctors ask me. The concept is the same. Whether you use the excimer laser to ablate the cornea or whether you use the femtosecond laser to make two cuts, okay? One anterior and one posterior plane, and remove the lenticule. Basically, you're debulking the cornea. That is the concept of any refractive surgery. All right. And smile is available for hypermetropia also now. Recently, they upgraded my machine for hypermetropia also. So I'm just going to show you a smile video. Smile is a very elite surgery, but it requires a little bit of learning curve. It has a higher learning curve. It requires a little bit of more skill than your LASIK or your femtosecond flaps. So here the laser is first cutting in the posterior plane and then the anterior plane. And instead of the flap, we have something called a cap. So there's a very small incision which you open up, and first we dissect the anterior plane. Make sure that you dissect the entire lenticule, separate the anterior plane, and then below that you go into the posterior plane to dissect the lenticule again. Once that is done, you can use a forceps to remove that lenticule. So whatever you ablated with your excimer laser, here you are removing it as a lenticule. That's all. Okay. Now the smile has a few advantages. Obviously, there is no flap. So any flap related complications can be avoided. That's first thing. The biomechanical strength of the cornea is much better because you don't cut a flap all around. Third thing is there is less dryness, because in a flap you cut all around and there is loss of, obviously you're going to ablate or cut the corneal nerves. So the dryness is more because corneal nerves have take a long time to regenerate. But here, since it's just a small opening, you're not cutting the corneal nerves all around, and hence the dryness profile is also very less with the smile procedure. So that brings me to the end of my presentation, because it's a long presentation, but a little bit about the how do I say, commercial part of also it about the laser. So first thing we always have to remember is refractive surgery is not a cosmetic surgery. It is also a therapeutic surgery because it changes lives. Okay, just imagine a patient who's wearing a thick glasses, who's waiting to get married, and her marriage is getting delayed, or she's not able to join a profession of her choice, like being a pilot or something. So actually, you're going to change his life by giving him a therapeutic procedure like refractive surgery to change his life. So definitely, first thing is we have to prepare our mind, saying that it is a cosmetic as well as a therapeutic procedure. Okay. Now this is a video of my son. Okay. Now he's in 12th standard, and the first thing he gets up in the morning and does is he looks for his glasses. He searches for his glasses. So because he has around 6 diopters of myopia, and I'm waiting for the day when I'm going to operate on him. Okay. So that is the kind of debilitation or the dependence of these patients on glasses. So we can definitely remove that. Second thing, it brings a change in someone's life and career. Okay, whether it's marriage or whether it's his dream job to become a pilot or this thing. So we have to offer refractive surgery in our practice. Everybody should offer. A patient who has a doctor who has an excimer laser can promote LASIK. Who does not have an excimer laser should at least start doing ICLs for his patients. So it is very important that you should offer. And it increases the revenue of the hospital, because a 15 to 20-minute job gives you a lot of returns. Okay, so we should always think it as a money churner also for us. So, and why should we offer? The prevalence of myopia is 22% in children between the age group of 5 to 15, and it is estimated to go up to 48% by the year 2050. So we will require more and more machines and more doctors who will be required to handle this situation. So definitely everybody should acquire refractive surgery. Either they buy their own machine or start using somebody else's facility, and we should develop our skill to do refractive surgery. So, and plus we also learn a new skill and advance, and we obviously advance in our professional career, right? And procedures are becoming safer and the results are becoming amazing with better technology. Now, recently we got the Wavelight Plus also. So that is a very customized form of excimer laser, where you can treat the whole eye aberrations also. So the quality of vision is amazing in these patients. We have better microkeratomes, better femtosecond lasers, and we can have customized profile for treating our patients. So we should develop, offer refractive surgery in our practices. Thank you. That brings me to the end of my presentation.
Thank you, sir. Just one question from the chat. In SMILE, what is the anterior cap thickness?
It's 110 microns. You can go up to 110. Below that, sometimes you can tear the flap. You have to be a little careful. Tear the cap. So 120 to 110 is acceptable.
Any other questions from our participants? Yeah, yes, madam. Please go ahead.
The SMILE parameters is the same, sir. Like every diopter 0.5.
No, SMILE takes flattening is the same, but SMILE takes a little bit of more corneal tissue. So I would say it takes around 16 to 18 microns of corneal tissue.
For a cylinder as well as sphere?
For a cylinder is something which, I take it as a spiro cylinder only, ma. I take cylinder also as one diopter, because see, let us err on the higher side. Okay. Why if we preserve more cornea, it's a better thing, right?
Fine. So the RSB is the same as
yes.
300, 350.
A lot of centers have made their RST for SMILE as 250, but I still keep it as 300.
Okay.
Good evening, sir. Thank you for
Dr. Mabruka.
Excellent presentation. It was very practical and very easy to understand. So, how does a wave light function?
The Wavelight Plus you're asking?
Yeah, wave
Okay.
light.
Now, this is an amazing technology which I've recently acquired. Now, what it does is, see, normally we do customized treatments and it takes only the corneal aberrations into consideration, correct? So we treat only the corneal aberrations, plus it also measures the angle kappa, the cyclotorsion compensation. Everything happens with our previous generation of diagnostics and treatment. But with the Wavelight Plus, what is happening is we are able to measure the aberrations from the whole eye, whether it's from the cornea, from the aqueous, from the lens, from the vitreous, everywhere. Okay. And then the machine gives its own nomogram. And the main thing is the refraction which we do in our OPD plus the refraction which the machine gives should match. If there is more than 0.5 diopters of difference, I don't think the machine allows us to do the Wavelight Plus, or InnoEyes it is called as, for the patient. Okay, so so basically the cyclotorsion compensation, the whole eye aberrations, the angle kappa, the visual axis treatment, everything is done. So it's a very customized treatment and the patient gets amazing quality of vision. The dryness profile is same as our femto because we anyway have to make a flap. Okay, so there is no difference in that. The patient should not have, preoperative dryness. All those parameters we have to follow. But apart from that, we can give a better quality of vision.
Okay.
So these will achieve a supernormal vision, sir. 6/5, 6/4, really like that works.
It's basically the investigation that is fed into the femto machine.
It's
and
automatically
the
fed.
machine.
It's automatically fed. We don't have to do anything.
Okay.
It just we have to approve. Yeah, the machine will tell us all the parameters are matching. Do you want to go ahead with the treatment? Once we approve, all the data is there in the machine. It's transferred.
So what's the femto-LASIK basically?
It's a femto-LASIK, which is more
Femto-LASIK, but
customized.
bit more customized.
Okay. And it's more expensive also.
It can be applied for SMILE also, is it?
No, SMILE is a different machine and different technology.
Okay.
You can do customized treatment with SMILE also, but not to this customization. You can only have cyclotorsion compensation and visual axis treatment. Okay. If you have an IOL Master 700, which is linked to the SMILE machine. These are two different technologies, two different machines.
Okay. Thank you.
Good evening, sir. Good evening, Lalit sir.
Yeah, good evening, Dr. Lakshmi. Please ask me. Please, how are you, ma'am?
Yeah, I am fine, sir. Sir, Contoura, what do you think about Contoura and this customized Wavelight?
Okay, now Contoura, as I told you, treats only the corneal aberrations. It takes into consideration the corneal aberrations, the cyclotorsion and angle kappa. But this takes the whole eye aberrations.
Whole eye aberration. Okay, sir. Great.
So one more doubt. These contact lenses virus comes with a small ulcers, a peripheral nebular opacity. Sometimes it is like mid-peripheral areas, which we treat and which heals. Now this patient asks, I want to get rid of. So what is your stromal opacity till which you go ahead with femto-LASIK? What are your, will be able to get a proper flap with these scars in place, which is not in the visual axis?
If it's a very superficial scar, okay, see, you can actually, since we have access to OCTs, if the scar is falling within the flap, this thing, right? I think it's maybe within 110 microns or 120 microns. I think you can go 5 microns below that flap and below that opacity and lift it. But if you ask me by and large, I do a PRK for these patients.
Tiny opacities in the peripheral also, you prefer PRK?
In fact, I would tell you the best thing works is a microkeratome because the microkeratome can cut through these opacities. Okay. Since I don't use microkeratome nowadays, I would prefer doing a PRK in these patients. Unless it's a very superficial scar, then you can get away by doing a femto. Otherwise, you will have, mostly excavated opacities, right? If it is, how do I say, a depression. Excavated opacities, I generally don't go for anything. I just go for a PRK.
Fine.
Okay.
So how long do you wait for these patients after the healing of ulcer?
At least 3 months, ma.
Okay.
At least 3 months. And when after surgery also, you put them under cover of some antibiotic, moxifloxacin or something, because most of the times we use antibiotic steroid combination. Along with that, you separately start antibiotic and steroids separately in these patients.
Fine. Last doubt for me.
Yeah, please.
PRK, what is your maximum power which you treat with PRK?
Okay, I have gone up to 10 diopters, ma. See, a lot of
10, sir.
10. A lot of people say that you can treat up to 6 is the limit, but I have gone up to 10, and that has given me amazing results. No issues.
So
There'll be a
those
little,
will be like thicker corneas.
obviously, the corneal thickness has to be there. The first criteria for any refractive surgery, cornea-based refractive surgery, the corneal thickness has to be adequate. You just cannot do it for anybody. All right. So if that criteria is satisfied, then you can go ahead with PRK. They're leaving a residual bed of 350, 360. So basically, at the end of the procedure, the cornea should at least be 400 microns, including the epithelium. After the epithelium regenerates, it should be 400 microns. Second thing is I should not flatten the cornea a lot also. I should not go below 35. Okay, because if you go below 35, the issue is, one, the corneal surface is very flat, and then the lid over the cornea, the tear film spreading over the cornea becomes this thing. So it is not spread uniformly. So that, the quality of vision is very bad for these patients. Plus the flat cornea also adds on to the quality of vision. So the quality of vision is not that great.
So the mitomycin C applications, for every diopter, it's like 10 seconds, like
10 seconds,
we do.
yes.
So I have read like articles, like maximum whatever they do, they don't cross beyond 30 seconds. Is that what you follow?
No. If I do for 6 diopters, I keep it for 60 seconds.
60 seconds.
Yes.
Fine.
It's not caused any issues. Okay. I do a specular for all my patients. Okay, for all my refractive patients. And if you're worried about endothelial, toxicity or something, I've done specular for patients at least 2 years follow-up. I bought a specular around 3 years back, 3 years back only. So in PRK patients also I've done specular. I've not seen any endothelial cell loss or anything in these patients. Significant, I'm saying.
Fine.
Because you're a corneal surgeon, you can throw more light on this. Your experience also, you can tell me.
No. It is just, I'm not a LASIK person, basically. My LASIK numbers are very few. So I just want to hear when a large volume surgery, because you will be seeing a lot of complications as well in LASIK. So I thought I should hear it from you. Then the last. Yes, please go ahead.
Apart from mitomycin, any other methods you adopt to reduce the haze for higher powers in PRK?
We tried dipping contact lens in preservative-free Nepafinac solution and all that stuff. Initially, there was some Nepafinac available earlier, preservative-free. It's not available now, but that doesn't reduce the pain much. The other thing which you can do is put a drop of cyclopent. There is a little bit of ciliary spasm in these patients. Okay, so that reduces the pain also. But see, PRK patients, we prepare them. 3 days, you will have difficulty. So, we prepare them well in advance.
Any role of Predford, sir? Have you tried that?
I start my patients on Predford from day one.
Yes, sir. That's what I also do. I have seen that the haze is very, very less in higher powers with Predford.
I give them steroid from day one. Under BCL, they have a BCL in their eye,
Till
and they are started on steroids.
BCL remove, till we remove the BCL, I usually give FML or some lesser steroids, and after the removal, I start them straight away on Predford. Is that okay, sir, or you can start with Predford straight away?
I've been using Predford for years now, so no harm. No
So
harm.
sometimes there is deposit on the BCL, sir. I've seen, I did it for 1 or 2 patients, but there was a lot of this white deposits with Predford on the contact lens.
You can use dexamethasone that way.
Okay, sir. Okay, sir.
So what is your post-op protocol for patients with LASIK? What regimen drugs you use?
I usually use gatifloxacin with prednisolone,
Combination.
which is a combination. I always use combination for my cataract as well as refractive. I've never got. See, there are 2 thoughts. I'm not saying no, but my point is patient compliance. We give them more drops, the chance of them applying is going to be less. So I give them only 2 drops. I think Dr. Mukul has. I think it's overshooting the time.
No, sir. I should apologize. I should have made this just a LASIK session. And if this was
actually, this presentation has many more slides.
Yes.
Amazing that I had to cut down all that.
No problem, sir. The thing we'll do is we'll request the audience also. Any further questions, please ask me in the Telegram group. I will forward it to Lalit sir, and I'll just get back the answer when sir is free, because even he has a pretty busy practice. Sir told me that by 9 I had to wind it up. I would thank you.
My practice is over. I'm leaving out of station tomorrow, so I have to go home and pack. That's all, nothing else.
Okay, sir.
So more sessions, refractive surgery sessions in future, sir. please plan.
I have
Yes,
an
yes.
amazing presentation on
Mhm.
LASIK complications, which we can have one of these days.
Definitely.
A beautiful presentation.
Sir, definitely we will do, sir. The thing is, I was apprehensive whether if I don't include cataract in sessions, whether we'll have participants joining. But seeing this turnout, definitely we can do
I
further
told you,
LASIK sessions. Yes,
20, 50, 45% are going to have myopia, right?
yes.
So definitely everybody is interested in LASIK now.
So I will conclude here itself, sir. Thank you so much, Dr.
Thank
Lalit,
you.
sir, for this excellent presentation. And I request the audience, any further questions, please ask me in the Telegram group. I'll forward it to sir. I'll get back make sure the reply is got back to you. Thank you so much, sir.
Thank you. Thank you. Good night. Good night, everybody.
Good night, sir. Everyone have a very good evening. Thank you.